How are you?
I'm doing great, thanks. Thanks for having me
Okay,
on.
thanks. And hi, everyone. This is Dr. Tofi. Welcome to HerniaTalk Live. I hope you can see my screen. Um, as many of you know, I am your hernia and laparoscopic surgery specialist. We're here every week on Hernia Talk Tuesdays. Thanks for everyone who's logged in live on Facebook and those of you who are with us on Zoom. As you know, all of this will be shared or and archived on my YouTube channel at HerniaDoc. And so let's get started. We have an amazing guest today, Dr. Sabrina Drexel. And you're going to like some of the stories we're going to share because we've already shared some of it before we started. And we're going to try and discuss it with you all. But Dr. Drexel is in private practice. She's a general surgeon trained in minimally invasive surgery. She loves hernias. She's a hernia specialist and works in Portland, Oregon. You can follow her on Twitter and other social media outlets at Sabrina Drexel MD on Twitter, and I think and Facebook, maybe Dr. Sabrina Drexel. But I just want you all to say hi to her. Hi there.
Thanks for having me on.
Oh, for sure. So, as many of you can tell, Dr. Drexel is much younger than me, and I didn't know this, but this morning she texted me and she said, "This is a very interesting topic we're going to talk about today because I'm in private practice, you're in private practice, and I thought we should talk about the fact that there actually are hernia specialists in private practice, and the whole concept of that and what that means and how it may be similar or different for the patient experience." And then she shared with me this video, which I will definitely post on my social media. Once we're done with this and I get home, I'm going to post it because I loved it. So many years ago, Sabrina was a resident and she was assigned. Oh, maybe you should tell the story because I don't know the backstory.
Either way, it wasn't that long ago that I was a resident, but I think it was 2019.
Yeah, 2019.
It was a chief resident here in Oregon at Oregon Health and Science on the acute care surgery. And my attending and I had this really interesting hernia case come in. At this point, I had already matched to minimally invasive surgery fellowship, so I kind of knew I was going down this path. But the patient that came in and had a week of groin pain and on her right side and a lump, and came in, got a CT, and she had her appendix stuck in a femoral hernia, which is a rare hernia, as I'm sure you talked about on the show.
I don't think, yeah, so appendix in an inguinal hernia is considered amnion hernia, but I don't think we have a name for one that goes into the femoral hernia. No one's named it. It could be the Drexel hernia.
It could be. Although I'll probably never see one again in my life. But
right.
But so we did the case. Oh, and she had a large ovarian cyst, adnexal cyst. We had to consult gyne. And so it was like a really challenging problem of like, how do we address the hernia and the appendix and this gyne issue? And so we submitted the video and the problem to the Journal of Trauma and Acute Care Surgery. And it's these fun talks that they do where it's like consult an expert, where, you know, EGS and trauma cases. And so of course the journal had me consult you.
Yeah, it was so cool.
And so I got to interview you. And at that point in my career, I honestly didn't know there were private practice hernia specialists. You know, you would really, and just last week you talked about kind of the hot spots of hernia care. And, you know, we mostly think about academic centers. And this was my first encounter with someone in private practice that was a hernia specialist. So of course, I did all my research I could about you. I was so nervous about saying your last name correctly. That was like, more than anything, was like, how do I pronounce her name so I don't make a fool of myself?
So funny.
But anyway, it's come full circle, the fact that you're interviewing me when I interviewed you 4 years ago. And
right. Oh, I loved it when you sent that to me. I totally remembered it. It was before I had this whole like microphones or anything. I was literally in my dining room recording the video. A colleague of mine, very close friend, actually, Matt Martin, who's a fantastic trauma surgeon and emergency general surgery kind of expert and such a talented surgeon. He's like, "Hey, do you mind doing this like expert video consultation thing for hernias?" I said, "Sure." I always say yes to him. And I totally remember doing the video, but you were a resident. I didn't know who you were at the time. And up until today, did not know that was you.
Yeah,
Like
no, why would
that's
you?
Sabrina Drexel that I know. And now here you are in private practice. So maybe you can, that's a great story. So thank you for sharing it.
Yeah.
Can you tell us a little bit after you did your fellowship? So you were at Cleveland Clinic.
I was actually at Case Western,
Oh,
yeah.
sorry, Case Western.
Yeah.
That's correct. You're at Case Western, which is like down the street from Cleveland Clinic.
Yeah.
Right, rivals. It's like USC, UCLA, ish. So, where are you from originally?
I'm from outside Seattle originally, and all my
Okay.
family's still in Seattle, so I'm from the
West
Northwest.
Coast. Yeah.
Yeah.
Okay. And then you did your fellowship, and then your first job was straight back in Portland, or how
Yeah.
was your trip there?
Yeah, this is my first job and hopefully my last job, because so far I love it.
Yeah, that's awesome.
Which I think is honestly just really special to find a great practice. So I did my residency out here in Portland. So, I had matched out here. I did undergrad and med school on the East Coast and was really ready to come back west, be a little closer to family.
Yeah.
And they had a great program here with a lot of women in leadership roles, which is
Yeah.
still not very well showcased across the US in surgery.
Yeah.
So I really responded to that. So I loved my training out here. And the nice part about our training is you do a lot of community work at the academic center. So you go to 9 different hospitals here in Oregon, because it's the
Wow.
only general surgery residency program other than one DO program in Central Oregon in the state. So there's not a lot
In
of
the whole state.
programs.
Yeah, it's the go-to place for the whole state.
Yeah. So another funny story is that now my current senior partner was my very first attending my very first day as an intern. So I knew my current partners as a trainee, and they really advanced my skill set as a laparoscopic surgeon for sure. And they do more foregut. And so when I went to fellowship, they were starting to look for another partner, and they wanted someone that specialized in hernia care, because they had a lot of patients coming in that had a little bit more complex hernias than they were trained to deal with. And so it was a good fit for me. We knew we wanted to come back to the Northwest. At that point, I had a daughter as a chief resident. So we kind of wanted to be closer to family. And it was just a really nice fit because they knew me and I knew them. And I knew their practice and things like that. I knew nothing about private practice and what that entailed. But it's been great. So yeah, I've been here for 2.5 years now.
Yeah. So for those of you that don't know, almost every major residency program that trains you for surgery is what we call an academic program, which means it's usually affiliated with a medical school, or a university. And the people are almost all just salaried on staff. Their goal there is to teach you, to do research, to advance their specialty, and to operate. And that's what we call the triple threat, right? So they're a great educator, great clinical person, and great researcher. And that's kind of promoted. And more programs are exposing residents to alternative ways of being a surgeon, like going to the VA, going to a Kaiser or other kind of closed kind of group setting, going out into the community and working at community hospitals and community clinics, and working with surgeons that are in private practice or employed in like a large group practice. So hopefully the goal of that is to see a variety of patients and also learn from the different types of practices there are. But most people who graduate think that their next job will be like similar to what they were trained in residency. Yeah. Private practice is not usually top on the list for most people. They're just not exposed to it. I certainly was not exposed to it. I was exposed to it very, very minimal, maybe less than 5% or 3% of my time was spent with any private doctor. And so in some ways I kind of poo-pooed them, like, we're better, we do our research and we give talks, and I like, and here I am. Right?
Yeah,
in private practice. And
but I think
your first job.
Yeah, I think a lot of people think the learning stops once you finish residency, and the involvement stops unless you're at an academic institution. And I think you're a great, phenomenal example of that doesn't have to be the case. So you're publishing, you're teaching, and you're a great clinician in private practice. And I am striving to emulate that. I definitely, so that, I get to work with the general surgery residents from OHSU at my hospital. So I get to do all the
Great.
teaching that I want. And we have medical students and PA students. I'm hoping to start doing some clinical research at some point, but life is busy starting up a practice and having 2 young kids, but that's definitely my next hopeful, part of my career that I get to be a little bit more involved in.
Yeah, usually what they say, oh, there's the academic docs and the private practice docs. I personally don't like those 2 designations because I feel like I'm more academic now in private practice than I was in a quote academic institution. I'm not bogged down by a lot of just the committee meetings and the staff meetings and all these other kind of useless waste of time rewriting handbooks and so on. I spend more of that time either advancing my patient care or doing research or traveling. We were just talking because Sabrina just came back from a major hernia meeting in India, right? How many thousands of surgeons were there? I heard over 1,000.
Yeah, about 1,500 surgeons from 40 different countries.
Yeah.
All about hernias. Yeah.
Crazy. I mean, in a good way. And you were among the faculty that were invited to represent, experts in hernias. You're joining me in 3 weeks, I think, two and a half weeks in Brazil at the International Hernia Collaboration. Sabrina's Dr. Drexel is one of our esteemed faculty for the International Hernia Collaboration meeting in Brazil, where we'll be. I mean, you're traveling and you're giving talks and you're representing advances in hernia care everywhere you go, alongside other surgeons that may be employed or in a practice where it's university based or the more kind of what we call traditional academic institutions. But you're the perfect example that clinical prowess doesn't have to occur in a university based or medical school based situation. And you have residents that you're training like I do. The residents love operating with me. First of all, I let them operate. And I teach them a lot.
Yeah. I think I get similar feedback. I hope I do. I think they enjoy, because we're in the community. I feel like there's a lot more throughput of cases. Our volume is just very different because I am first and foremost a community surgeon, and I don't have designated time for research and kind of maybe some of these non-clinical tasks that sometimes academic surgeons and faculty do have. So we're in the OR typically 3 days a week and doing really advanced stuff with the residents. So I really enjoy teaching them and getting them more skilled in their laparoscopic and robotic, especially cases. Yeah.
And I think some of the stuff that bogs us down in these institutions, we don't necessarily have to work with. There's a question here. It says, Dr. Tophi, are you not still professor of medicine at your medical school clinical track? That's actually a good question. Do you have a professorial title of any sort?
I'm like a clinical associated staff, I guess, but no, nothing formal. How about that?
Yeah. I mean, when I first started my first job, it was in a traditional tenure track, full, so it goes assistant, associate professor. That's kind of like, so assistant professor, associate professor, full professor, and then emeritus, whatever, when you retire. But when you're employed and part of the medical school officially, then those are the tracks you can follow. And that's what I initiated. And I thought one day I'd be like, chair of a department. That was my goal. But then when you go into private practice, those things change. First of all, you're not employed by them. So whatever you're doing is voluntary. So your title changes. It becomes like either clinical professor or it becomes like voluntary clinical professor. They kind of want to make sure there's a distinction in titles because it also implies a different pay thing. But also I'll tell you, I'm having a really hard time getting my professorship. I applied to be it's even stupid. It's a voluntary professor, voluntary clinical professor of surgery. It's not even like tenure track or anything important. It's just a title. I feel like, I might as well have the title.
You're putting the time in with your
I've put
residents.
the time in for my
Yeah.
residents and the medical students and the undergraduate students and the women in surgery group and teaching classes and so on. So it's nice to have the title. I don't really use the title because it means literally nothing. 3 years. It's been 3 freaking years. They lost my application twice. And then everyone kept, I don't know if they got fired or they kept changing jobs. And then again, my application was lost. And now they're saying, oh, you know what? We're actually going to revamp our whole, like the dean of the medical school is revamping everything. So we're going to put your application on hold for that. But I'm totally over it. Like, I don't
So you have
care.
no official title, right?
I still have my associate professor title, but for the past 7-8 years, I could have been professor, and I applied for it a little over 3 years ago. I'm still waiting. It's so ridiculous. It should be like a 3-month process.
Easy thing to do. Yeah.
It should be a 3 to 6 month process.
But like you said, the titles
means nothing.
Don't mean a whole lot. Yeah.
Yeah. Whereas to me, it was very important early on in my career. It was very important, the titles and this and that, but it means nothing right now.
Yeah.
So is there any reason why you can't still wind up chair of a department position? No, in fact, when I was switching from one job to the other to become private, I finally chose private practice. I had a couple different chair opportunities locally. To be chairs of departments, and I turned them all down. I can still do it if I wanted to. It's just having felt the freedom of being your own boss and taking your career in the direction you want to take it without someone above you saying, Sabrina, why were you in India? That's a very long trip. Or why are you doing 2 international trips in 1 year? We need you more. Like, I don't have anyone saying that to me. You probably don't either. And that is priceless.
Yeah.
Someone not being on your shoulder, constantly nagging at you because they have an idea of what you should be doing and that's different than what you're doing. Understanding that, like, you and me both probably would have been really great employees because we would do everything well, right? We'd spend time, we'd educate, we'd be long hours helping and teaching and promoting and doing everything. But at the end of the day, like, it's so nice to not have that extra burden. I think people who are not in private practice don't get it yet.
Yeah, they haven't, and granted, I haven't seen their side, so not to say there's not.
I've been there.
And the biggest thing with private practice is I'm not affiliated with any one hospital system, so you truly have to get your own referrals for patients and things like that. And to answer that question too, yes. So in addition to the academic hospitals, any other non-academic hospital system typically has chairs of departments and things like that. So I'm currently, chair of our robotic steering committee at my hospital because I care about the robotics program and advancing it. And you can influence the direction. And it's a voluntary position. I don't get paid. I don't get, and it's extra time and emails and meetings, but I care that our program continues to advance and we do more surgery minimally invasive rather than open because it's better for the patients, number one. And so that's why, I'm like you, I pick and choose what I'm involved in because, and it comes down to what am I passionate about. So yes, you can certainly have plenty of leadership roles, even in private practice, even though I'm not employed by the hospital, they have their own general surgeons. But they asked me to be their robotics chair because I'm the one that's doing it and promoting it, probably more than their, employed surgeons are. So it doesn't mean you can't be involved.
Yeah. Now, how many hospitals do you or surgery centers do you work out of?
2 main hospitals, 2 main surgery centers, but I have privileges at 4 different hospitals because we're a group of 5 surgeons and we span Vancouver, which is Southwest Washington, and across Portland. So yeah, we can cover each other and things like that. So I have a lot of access to a lot of different places.
Wow. And is there a reason why you choose to operate at one versus another?
Partly insurance. So we have one
Yeah.
group of insurance here, Providence. I don't know if you guys have it
Yeah.
in
Yeah.
California, but so you have to operate at their hospitals, or their affiliated, surgery centers, that kind of thing. So it's partly insurance. And then location, what I love about our private practice is we try to go to our patients rather than making our patients come to us. So,
Yes.
we have a clinic based in Vancouver, we have a main clinic based in Portland, and then we have a satellite clinic on the west side of Portland, about 20 minutes away. And so we host office hours at different places to try to be convenient for patients. And then having privileges at all these different places, then patients can kind of get a choice of where their surgery is, what's convenient, what's going to be convenient for them based on the constraints of their insurance.
And then maybe you can explain also access of patients to you, how different that is than people that are working at an institution usually.
Yeah. Very easy access. Again, another thing I love is that we get to shape our practice how we want. We get to tell our medical assistants and that just ask us questions about patients. So, if patients phone in and have a question our medical assistant can't answer, we'll answer it very quickly, usually, within the day. Patients that need urgent problems fixed. So for example, a lot of primary care docs, might see a patient in clinic that has an abscess, a skin issue, not hernia related, but, and they don't feel comfortable draining it. Rather than sending them to the emergency room, they just call our office. One of us is here same day. We just see them same day appointments.
Yeah.
And rather than sitting in the ED for hours, sure, I'll see them in between surgeries. Like they might have to wait 30 minutes for me to finish surgery, but I'll just run up and deal with it. And an employed system that would never cross their mind to alter a schedule or do last minute appointments. Or I had a patient show up yesterday that thought their appointment was the next week. And I'm like, of course, we'll just see them. They're here. I'm not going to send them away and make them back next week, but I have full control over those decisions versus in a different model. You may not even be aware that patient showed up and they'll just say, sorry, doctor can't see you today. So I love.
In fact, they may not even hear that patient is asking. Like they may just call the front desk, and the front desk doesn't really have a relationship with the individual surgeons because they're like employed by the hospital separate from the Department of Surgery, for example. And then you may not even know that your patient wants to see you because they just call the front desk. That coordination isn't there necessarily.
Yeah, so that's what.
And the wait time to see you for like a new patient?
Less than 2 weeks.
Yeah, same.
Our model is if we ever have a wait time more than a couple weeks, that means we need to hire more providers. So, I joined in August 2020, and we've had 2 more surgeons join us since then because we've been so busy. So it's just a very different model than urgent appointments for whatever. You have a really painful hernia, you have a gallbladder issue, whatever it is, we'll get you in if you feel like it's urgent, typically within a week. And we have the flexibility, and our staff understands that we're happy to see patients on off hours, even if it's not, a clinic day, that kind of thing. So
that's the sign of a very functional practice.
I feel like that's how medicine should be.
Yeah, it really should.
Unfortunately, it's not, because I've been on the patient side and you're stuck on a phone tree and you don't get an answer for 3 days, and it's equally frustrating as a physician. Yeah. As I'm sure every patient has experienced that. So we don't have a phone tree. We just call us, we'll talk to you. And luckily, you hopefully counsel your patients well enough that they're really only calling in if they have an issue, and then you want to know about it,
Yeah, I totally agree. I think that's one of the beauties of private practice. Do you think the charges or the pay scale is different accessing a private doctor?
I don't think it is for the patient. I mean, it should be the same in terms of billing and copays and, the surgeries you get signed up for, all of that goes through your insurance. I don't believe is different from the patient side. From the, physician reimbursement side, you see it differently because most employed surgeons work in this RVU or relative value unit. So each surgery has a number of RVUs attached to it, versus in private practice, it's kind of just what insurance do they have and what do you collect from that? Now, most of us, we take, all insurance, and we really just treat patients as they should be treated no matter what insurance they have, but you may get reimbursed differently based on their coverage.
Yeah, the pay scale is a little bit different, like you said, because a hospital also makes money on radiology and laboratory services and ER visits and nursing care, certain nursing cares or procedures, whereas you don't have access to income from MRI that you order.
Yeah.
And so really however hard you work, is reflected in your income. Whereas on the institution side, there's so many other players that pump in income for the hospital that that kind of volume or activity is not necessarily mandatory to maintain the same salary or income. Yeah.
And I think one more point that's probably important to educate people on is, this topic of surprise billing has been brought up a lot in, legislature settings and things like that. And I think it's partly because, most of the public doesn't understand how the medical system works. So if I operate on a patient at a hospital, my billing is going to be separate than what the hospital bills, because I'm not paid by the hospital. And typically the anesthesia team or your anesthesiologist is also going to bill separately because they're typically not employed by the hospital, although, there's different models where sometimes they are. So for one surgery, it's very common to get 3 different bills, one from your surgeon, one from the anesthesiologist, and one from the hospital. And so it's not necessarily surprise billing, although, people get frustrated when they got one bill and then now they're getting more. And I can totally see why that's a point of confusion, but it's because, they are separate systems, and how I get paid is different, reimbursed is different than how the hospital does.
Yeah. Yeah, so there's a question that was submitted, which I think is interesting question, because it kind of points to how people think hospitals are run. So it says, as a surgeon who runs a private practice, how do you use the time you gain by not having to perform a minimum number of surgeries for a hospital? But hospitals don't give us a minimum number of surgeries, and they don't pay us, and we don't pay them for using their facilities. It's completely independent, but it's mutually beneficial for us to take our patients to the hospital, and the hospital to want to take care of our patients. Does that make sense?
Totally. Yeah.
Yeah.
And I think, there's no minimum. What most hospitals have set up is what's called operative block time, where you're signed up. I have, for example, every Friday I get to operate. And so if you're not filling up that day every, over the course of a quarter, maybe if you only used 50% of that time, they might cut your time down because there might be other surgeons that want to utilize that time. So they do track how much you're filling the allotted time they have for you, but there isn't a minimum. So like some of these hospitals that my partners are busier at, I don't have dedicated operative time there, but I can add on cases as needed since I still have privileging there.
Yeah, exactly. Yeah, this disconnect between like hospitals and we're very independent, and by design we're independent. They can't like mandate us to operate there for any of our cases. That's really our choice, and like you said, sometimes affected by the type of insurance. So there's another question that says, does going to private practice surgeon necessarily raise the cost for the person? And why are we getting 3 different billings instead of one total for the surgery?
Yeah, I'm not sure what time that question came in, but I'm happy to reiterate that, no, the billing should not be different going to a private practice surgeon versus an employed surgeon. What's more important is whether they're in network or out of network with your insurance, but otherwise the billing should be very similar, if not the exact same. And so, my office is very good at checking to make sure patients are in our network before we schedule them for an appointment, so that they're not getting out of network billing based on their insurance. And then again, for most surgeries, it's typical, I would say, to get at least 2 bills, so at least the hospital bill. And then around in our area, at least, most of the anesthesiologists are in private practice groups. So they are not employed by the hospital. So they bill separately. And then if your surgeon is in a private practice group, then they are also going to bill separately. If the surgeon's employed by the hospital, then that, the surgeon's fees will be included in the hospital bill. So it's not necessarily more billing. It's just where the money is going is different depending on whether or not they're employed by the
but even that is even if you go to, let's say, a hospital, everyone's employed, you still will get separate bills. It all goes to the hospital, but there are different buckets of money. So for example, the surgical department will bill for the surgeon, the anesthesia department will bill for the anesthesiologist, the hospital will bill for the use of the hospital, probably lab may be included in that, and medications.
Yeah.
And like nursing and all that is already bundled into that hospital cost. But regardless of where you have your surgeon, who has it, you will get multiple, at least in the United States, you will have multiple bills. The only time you'll get one bill is if you're at a Kaiser Permanente or some other kind of closed system where it's one employer that does everything.
Yeah.
And it's all into one bucket. But even in hospitals and so on, it's multiple buckets, so you will get multiple
Bills. Yeah.
bills.
I think sometimes it's confusing when it doesn't have
Yeah.
the hospital name on it versus when they're all employed.
Yeah.
It's all coming from the hospital. But yes, I totally agree. It can often come in different envelopes from different departments and
Yeah.
be like, didn't I already pay this
It's
bill?
very complicated. Sometimes our
yeah.
patients call us and they're like, I thought you said I won't be billed. And I'm like, because we do everything up front. We tell you up front everything. There's no surprise anything. It's like, oh no, this was that from this actually the hospital is billing you, and then my office helps figure out from the hospital like what is actually going on for the patient, because it's very complicated and confusing.
Yeah. I have learned a lot about business in the 2.5 years in private practice. So and
I mean, that's
it's
good.
it's confusing even for us. So
okay, so here's some follow-up comments. One is, I've had that. I was most curious from a total cost perspective, was a total surgery the same cost for like services? It depends. It depends on how contracts are negotiated and so on. So I only work at one hospital. I tried to make it clean. Like, I don't like running around or doing any of that. However, our hospital, which is a great hospital, has increased its cash rates, and access to robotics has become a little bit difficult in the outpatient setting. So I am now credentialed elsewhere where for my patients who are cash only, I can get a better rate for them. Still at good places, but the main hospital is just super expensive. Like, it's so ridiculously expensive. I'll give you an example. Something that used to cost $10,000 outpatient is now close to $80,000, which for cash, that's just a ridiculous amount for an outpatient operation. So we're looking at other like opportunities for our patients. So that's why I am increasing the different places that I'm privileged in, but it's purely to be able to help our patients with more affordable care.
Can I ask, do you go to a surgery center at all, or is it like an outpatient ambulatory center within a hospital system, or what's your setup?
Both. So our hospital has an outpatient hospital or outpatient center attached to it. In addition, it has 2 other outpatient surgery centers actually in the building where my office is. So right here where I am, upstairs and then down the hall, there's 2 separate surgery centers. I usually operate at those, which is great because it's still the hospital affiliated surgery center in network, but I don't have to drive anywhere. It's right here. It's literally down the hall. It's so awesome. I'm very lucky like that. And as a result, also my nurse is my circulator. And so she, like it's just a perfect scenario. It's such a perfect scenario. I never want this to ever change. So yeah, that's but we don't have a robot in the outpatient surgery center in our building. It's just not a financially doable situation. So I'm dependent on the hospital for all my robotics cases. And that can become difficult because you're competing with, we have 9 robots, but we're still competing for
other surgeons
for OR space. Yeah. Here's another question. In Australia, we have Medicare, which is free treatment and surgery in the public system. If you go to a private surgeon and you have private health insurance, you can pay a gap. If you are a military veteran and have a Department of Veterans Affairs gold or white care, your treatment is also free. This is great. But how many hernia specialists do you have in Australia? That's the question. Unfortunately,
and I'd love to know, what makes people decide to go see a private surgeon versus not. I think that sounds more similar to UK and Canada systems, but here in the US, what private practice means is still very different because we're still part of the health system and take Medicare and Medicaid and
Yes.
all insurance plans except for the closed systems like Kaiser, like
Yes.
you mentioned.
Should
So
we do some clinical questions?
sure, yeah.
All right, because they're piling up. Okay.
Okay.
I am a male with a BMI of 29.4, so that puts him technically in the overweight
Great.
category.
Okay.
Muscular build. I am having a Shouldice Inguinal Hernia repair. My surgeon said he can make it last with my BMI. I appreciate your thoughts. So the question is, if you're outside the normal weight scale, muscular with an overweight category, a tissue repair like a Shouldice, is that still feasible, or does it have a higher recurrence rate?
I think it is very dependent on the surgeon and ensuring that they do high volume tissue-based repairs.
Yeah.
In my hands, I was not trained to do many tissue-based repairs.
Yeah.
It's still part of my practice that I want to, evolve and learn more. But I don't necessarily offer a tissue-based repair, and I certainly wouldn't in an overweight patient. But that's my practice. But certainly if you go to a high volume surgeon, I think you could have a safe tissue-based repair, certainly.
So the Shouldice clinic that does Shouldice all day, every day.
Yeah.
I think their cutoff is 25 or 26 BMI.
Okay.
They would not offer a Shouldice, and they just want you to lose weight. I think it depends. Like, I do plenty of tissue-based repairs. I do more now than I used to. And it depends. If you're 29, you say you're muscular build and you're not carrying all of it in your belly, then likely you'll do just fine. But if it's all belly and you have thin legs, for example, then that's a lot of extra abdominal pressure that you're putting your Shouldice repair against. So, here's another question. Same patient, male with 29.4 BMI, muscular, small and painful 9mm inguinal hernia, and I don't want mesh as I'm afraid of what could happen if it goes wrong. My surgeon said he can do the Shouldice technique, but my BMI may be a little bit high. It is, I would say it is a little high for the classic Shouldice, and the Shouldice clinic would probably reject you purely based on your MRI, or your BMI. What are your thoughts in general about weight and other risk factors and determining like the best surgical technique for patients?
Yeah, I think that's a great question.
Yeah.
I definitely, and I think that's part of the fun of surgery or of hernia care specifically, is that every patient's different and every hernia is a little bit different. And so you kind of do tailor the technique to the individual patient. And that's what makes hernia care maybe a little bit different than other general surgery subspecialties like colorectal or breast or things where it's kind of the same surgery regardless of patient factors. So yes, obesity we know is a risk factor for hernia recurrence.
Yeah.
And so in a,
for all bad outcomes from hernia repair.
Yeah. So, I counsel patients, the three main risk factors for recurrence is going to be obesity, active tobacco use, and poorly controlled diabetes. So for an elective repair, I am ensuring that all of those are at least as optimized as possible.
Yeah.
Now, certainly patients, we typically with a BMI less than 40 or so can offer some type of repair relatively electively, although I'll often ask patients to try to lose some weight if they can. But I tend to do a more broader based repair, for example, a primary umbilical hernia, that's 1 or 2 centimeters. In a thin patient, I may just do an open suture repair, but in an obese patient, I'll tend to more do a robotic, transabdominal peritoneal approach to get a wider piece of mesh in to help counteract some of the increased pressure on their abdominal wall. So it is an important consideration. In addition to age, I also look at, a 40-year-old, I want the one repair I'm going to do to last the rest of their life. So I might make a different decision than in a 70-year-old or things like that. So I think that's part of the art of hernia care, in all honesty, is really, we have so many tools in our tool belt now on how to fix a hernia, and really picking out the right one for each patient is what keeps it interesting from my perspective.
And I would say, I understand the arguments for and against tissue repair versus mesh repair. And the comment is, I'm so concerned about things that can go wrong with the mesh repair that I want the tissue repair. Well, things can go wrong with a tissue repair. And if you're overweight or have other risk factors, like you mentioned, tobacco use, diabetes, chronic cough, constipation, these are all things that can promote bad outcomes after your hernia repair. Then you know what? You're going to tear that tissue repair. And that is a very painful situation. So that's the reason why chronic pain is very similar for tissue repair as well as mesh-based repair. And part of the chronic pain seen with tissue repair is you're tearing. And you're
Yeah.
tearing, and that's very painful, or there's a nerve involved as part of the scar tissue or the hernia repair. But let's take the nerve issue out. Perfectly good repair. If you're doing it in a patient that has increased abdominal pressure, it's going to start tearing, and that's very painful, and that's where the chronic pain comes from. So, that's where the whole tailoring comes into place, right? To determine what's the best repair per patient. People always ask me, well, what would you do? I'm like, well, I'm different than you.
Yeah.
So whatever I think may be good for me, may not be good for you. And this is a great example of it. Here's another question. I have a recurrent indirect inguinal hernia, but I'm not sure whether it is symptomatic. Sometimes I have one-sided testicle heaviness associated with tenderness to light squeezing and downward traction. Could this be related to the hernia at the internal ring? So it's testicular pain or discomfort, I should say. Could that be related to a recurrent indirect inguinal hernia?
Yeah, it's a great question. Assuming that the pain is on the same side as the hernia, I do have patients that come in with this testicular pain. They almost describe it as like a vice sometimes, like this squeezing, pulsing sensation on the testicle, and that can certainly be related to a hernia. So I think doing a thorough investigation of that patient to ensure it's not any other factors causing the pain or any complications from the prior repair. They didn't offer what type of repair they've had in the past, but certainly there could be other reasons for testicular pain, but it can be a sign of inguinal hernia.
Yeah, that's exactly right. What you said is very key, which is after really working it up, what I see sometimes is patients clearly have another problem. But the hernia is an obvious one. So the surgeon, oh, we'll fix your hernia, but it was their hip or it was their testicle or varicocele, hydrocele, epididymal cyst, all these like spermatocele. There are all these other reasons why you can have testicular pain, and it wasn't their hernia. So now they fixed their hernia, and their original pain is still there because that wasn't because of the hernia, and they sometimes have a complication from the hernia repair.
From surgery,
so now they have two problems. And so that's why what you said is very important, which is let's figure out exactly why you have the pain. And if we rule out urologic problems and maybe a musculoskeletal problem, then let's fix the hernia and see.
Good. But the counseling is key. And I think definitely with those patients, I always say I cannot 100% guarantee that your pain is from the hernia, but surgery is typically very safe, and that, I'm hopeful that it will take away your pain. But it's all about that pre-op workup and then counseling about expectations. Yes.
Yeah, we had other questions submitted. I think we already reviewed this one. Oh yeah, here it is. What are the pros and cons of getting hernia surgery from a specialist in private practice? I personally think it's the closeness of the care, and the timeliness of the care. Although I'm sure there are people in institutions where it's a very functionally well run office, but it tends to be better in private practice.
Yeah, I would echo those sentiments. I think there's simply not enough hernia specialists, especially in the US, and kind of your talk last week about hotspots. There's only a few places in the country that even have a designated hernia specialist. In our community in Portland, we have a fabulous hernia center at the academic institution at OHSU, but they have a 6-month waiting list to see a surgeon, and then often a 6 to 8 month waiting list to get in the operating room. And so the benefits of finding other specialists is they're needed in the community because plenty of these patients don't necessarily want to wait or need to wait. They oftentimes it's inguinals and umbilicals and, small, medium ventrals that can certainly be addressed safely by a hernia specialist in the community. And so, yeah, I think that's one of the big benefits is just access to care. Yeah.
I think access, I agree. Can any surgeon start a private practice? Are there any direct or indirect checks in place to ensure that the services offered by a surgeon in private practice are up to some quality standards?
That's
So yes, anyone can start a private
question. Yeah.
practice. I mean,
Yeah.
it's risky. It's like starting a business, right?
Yeah.
But yeah, that's a good question about checks in place. I'll tell you, I know a lot of surgeons in private practice that offer hernia repair, right? Because we're all general surgeons, board certified, and hernia repair is part of the training and also the practice of most general surgeons, not necessarily specialists only. But what do you think about these like direct or indirect checks on their practice?
I would say that society actually has some indirect checks that are probably higher standards than community employed or even academic surgeons, because like you said, you're starting a business, you have to pay staff, employees, rent, et cetera. And if your referral pattern is very different than someone that's employed, because for the most part, they haven't worried about who is sending them patients because it's naturally their hospital system. And so if they don't have good outcomes, that may not change their referral base.
True.
But if you don't have good outcomes in private practice, the people sending you patients are likely going to turn to an alternative that may be within their hospital system. Many of the primary care docs that refer to me have surgeons in their own network, in the same hospital system, but they know that I offer exceptional care to my patients, and exceptional quality in my surgery. And that's why they keep referring. So I feel like, like you said, it's risky and it's hard to start out in private practice where you have to build your brand kind of thing, unlike an employed surgeon. So I feel like the standard is actually higher just based on that.
True. A lot of the employed kind of institutional surgeons, they're just sitting in the office and patients come to the office because the hospital has already invested in a network or a referral base. Whereas in private practice, it's really up to you and your ability to make your own referral base and maintain that by offering good service. If you're a bad private practice surgeon, you're not going to survive. Basically, it kind of checks on itself. That said, hospitals do have a peer review system. So if you're performing egregiously bad surgery or have bad outcomes, you will get quote checked by a peer review system by the hospital. And that's a good way to either be put on some type of probation or even lose your privileges at the hospital. So there are some screening.
And I think all surgeons are certainly held to the same accountability and minimum standards at any hospital and even at surgery centers. I have to do random peer reviews of other surgeons at that surgery center quarterly. So there's definitely standards in place. They're not specific to private practice. So
here's a question. What are the options to close a medium to large ventral hernia after intestinal surgery? I have a 5 to 7 centimeter with some call it a rectus diastasis, but that's clearly an incisional hernia. Probably the radiologist called it a rectus diastasis. It's not. In the center abdomen, they are not connected. It's been suggested to have a component separation without closing both layers and TAR surgery, which is a posterior component separation. I don't want a TAR and I don't think it's necessary. So 5 to 7 centimeter incision hernia, basically.
And again, this is where I say it's all dependent on that patient's individual characteristics. So is that a 4'10", 100-pound lady, or is that a 6'1", 250-pound male? Because those are two very different patients with a 5 to 7 centimeter hernia. So it's and
5 is different than 7. Those 2 centimeters make a difference. They
do. And then the size of their muscles, so those rectus muscles that run up and down, the width of them is important. How much weight is in their belly? Have they had any prior repairs? Is the hernia from an incision versus a primary hernia changes what I offer. So
let's say 5 centimeter incisional hernia in the average patient.
Yeah. I think that would be a great case for, potentially an robotic or a minimally invasive approach to a retrorectus, I think would
Yep,
often be needed at that
exactly.
size.
Mm-hmm.
Most 5 centimeter hernias would not need a TAR or a posterior component
Correct.
separation in my patient population, at least,
Correct.
unless there's extenuating circumstances as to why that tissue can't get closed with just a retrorectus, but that would probably be my go-to in the average patient.
Yeah, so that's an open reef stop or retrorectus or robotic eTEP, right?
Yeah.
Would be another term, or a robotic reef stopa, some people call
Yeah.
it. Yeah. With mesh. 7 centimeter, how does that change what you offer?
Yeah, like you said, those 2 centimeters do make a difference. And that's a little bit where I get to closely measuring that retrorectus space. So we actually measure the width, and we have this kind of general, what we call the Carbonell rule, but
Yeah.
we measure the width of each rectus muscle. And if it's more than double the width of the hernia, then we probably can get that closed without that posterior component separation or that TAR.
Yeah.
But at 7 centimeters, you're getting a little bit closer to maybe needing that component separation to, again, the whole goal is to offload the tension medially to be able to close that hernia defect without tension on it, so that hopefully it holds.
Yeah, and I have an issue with this last comment. It says, I don't think a TAR is necessary. So if you go to the right doctor and they're a specialist, then they determine what's necessary. When you're in the operating room, usually your specialist will have a plan, right? We have a plan. Can this be done robotically, laparoscopically? Should it be done open? And what are the pros and cons in that specific patient? So for a 7 centimeter, that's a good one because that's tricky. Sometimes you can do a retrorectus for 7 centimeters. Most of the time you need a little bit extra help for a 7 centimeter. And that usually involves taking a retrorectus and expanding it to a TAR. And so sometimes you don't know in the OR. Sometimes you're in the OR, like, oh, wow, this actually came together very well. Or you say, oh, wow, I expected this to close and I can't. So I need to switch my Reeves or my retrorectus to a TAR. So to claim ahead of time that I don't think it's necessary, and then to bind your surgeon's hands, or try and find a surgeon who will say, I will absolutely not do a TAR, I think is not the right way to approach the problem. I don't know how I feel strongly about that because I have a lot of patients that come to me and they only want a certain thing because they've done their research. But I feel like they kind of lose the forest looking for trees, and I can give them a 30,000 viewpoint. I can give them the microscopic viewpoint. Like, my vision is different than them. What do you think about that?
Yeah, I think it's all at the end of the day of trust in the hands of your surgeon. And I think
Yeah.
that's what makes our job really special when you get even though our relationships with our patients might be short-lived compared to a primary care doc, that it takes a lot of trust to have a surgeon take you to the operating room and let them,
True.
cut you open and fix what's right. But trusting that we'll do the right thing in those moments, because certainly there's times I've been in the OR where I'm having to use plan B or C because plan A didn't work.
Yeah.
And that's part of surgery, and it's stressful for us when we're doing not what we thought we were going to be doing. But yeah, it's hard to have a patient come and tell you exactly what they want, because sometimes they may not be like the patient they read online or things they read online, and that they're different for X, Y, or Z. So
yeah, I agree. Here's a comment. It says, I have a small inguinal hernia. I have no pain coming from the actual hernia. However, I have a palpable, hard, long, painful lump higher up on my inguinal ligament region. I've had multiple scans and only the hernia shows. The surgeon is perplexed as to what the hard pain palpable lump could be. I have no pain in the morning, and the pain comes in the afternoon, and the pain will remain for several days if the lump is pushed or pressed. I mean, sounds like a hernia to me. The doctor wants to do a laparoscopy to look around and an open repair the same day to also fix the hernia. What are your thoughts?
It changes if this is a male or a female.
Male.
Because
Yeah,
male.
it looks
Okay.
like male. Yeah, it's a male.
Yeah, I mean, it sounds like that's a reasonable thing is to proceed, since we know that there's a hernia, and the palpable lump certainly sounds like, the hernia is reduced in the morning, and then as you stand up and move around, there's more pressure on the belly, and so the hernia is protruding, is certainly what it sounds like described. Sounds like maybe it's in a little bit of an odd position or just a little higher than they expect, but you know,
Could be an
everyone's anatomy,
interstitial hernia.
yeah, everyone's anatomy is a little bit different, and yeah, it could be going between the layers there, but I think that's reasonable. In my hands, if I was going to go in laparoscopically to look around, I'd probably just end up doing a laparoscopic or
Yes.
posterior repair. I personally wouldn't see the need to do an anterior approach if I'm wanting to see posteriors as well, but there could be a reason the surgeon was deciding that, like if the palpable lump isn't a hernia or something else and they wanted to visualize it, you know, in the OR. So
But if you have imaging, you should be able to
yeah,
see all of it and
yeah.
not need a laparoscope to see more. That's I feel like for some reason they're not believing the imaging, which I don't know why. And then the other thing too is this could be what's called an interstitial inguinal hernia. So it doesn't necessarily protrude out, it protrudes up and through, up and laterally through the tissue planes. And so it's not like it's kind of an interesting inguinal hernia, but either way, the repair can be done open. It can be a Shouldice repair. But I would trust the imaging and the physical exam and the symptoms. And sounds to me like it's just a hernia. I mean, it's not just a hernia, but that it's just
Yeah,
a
without
hernia.
seeing the pictures and things, that's what it sounds like based on the
Yeah,
the
yeah, that's what I
history.
agree with.
Yeah.
Yeah. Okay, a couple more questions to go through. So let's see. Would you recommend for a hernia specialist to start a private practice only after many years of working as a hospital employee? If yes, can you consequently say that surgeons offering their services in private practice are generally the most experienced surgeons?
What an interesting question.
Yeah.
I guess I would say no to the first one since I came straight into private practice from finishing my training. So I didn't work as a hospital employee. Again, I'm always very curious what it would feel like to be an employee because there's just different stressors on the job of being a surgeon. But I don't think you have to have been employed to go out into private practice. I'm sure you have knowledge that probably would have been helpful, but again, I went into practice with two senior surgeons that have helped me through this. So and I would say the most important thing is having, you know, good partners when you're first starting out. So no,
True.
you can't really say the most experienced are in private practice because we're all at different stages
Yeah.
in our careers.
Yeah,
So
there's some really amazing private practice surgeons and some really amazing surgeons in institutions and vice versa, I would
yeah.
say. I have a question for you because so I went backwards, right? I started at a county base and university base 4-year, like tenure track situation. I went to a community hospital and now I'm in private practice. But I think that was really good for me because my first 5 or 6 years, even though I gradually became more hernia specialist, I was doing everything, you know. I would
Yeah.
just show up every day and save lives. That was my job. And now I'm very, very specialized. I rarely see a sick patient and I rarely have to do like gastric surgery or, you know, I do maybe one gallbladder or two a year, maybe in people that want me to do it, but it's like not my thing. What was your experience when your first year or two? Did you do other general surgeries? And what do you think about people that go straight from fellowship to 100% like pure hernia? Do you think that's okay? Or do you need to know more general surgery under
Yeah,
your belt?
it's a great question. I think it's certainly okay, especially if they're at an institution that supports their practice to be 100% hernia, if that makes sense.
Yeah.
And that typically is going to be more an academic center with a hernia specific center or an ab wall center. I actually know I take general surgery emergency room call. So I
Okay.
still think I'm a general surgeon at heart. I still have to come in the middle of the night for emergencies and do colon surgery and gallbladder surgery and take out appendixes and things. I love my passion for elective hernia care. And I think my residents always joke that I happen to be the one on call when incarcerated hernias come in.
Oh, that's
And the
good.
benefit of me being on call is, you know, my patients are going to get a robotic repair when they would have gotten an open repair probably by anyone else.
Yeah.
So, you know, that part is fun to blend my passion for hernia surgery with acute care surgery.
Yes.
And I have multiple colorectal partners. So, you know, the stuff that I really don't feel comfortable doing or that can wait till the morning, I will usually ask them to help out with their due because they're the specialists in that field.
Sure.
So, yeah, I definitely have some general surgery, but my elective practice is 90% hernias. A small portion of my fellowship was also advanced endoscopy. So I still do that. And that's kind of
Oh, wow.
my other passion. Is doing kind of interventional endoscopy. So that's the beauty of private practice is I get to kind of craft my practice the way I want it to be. So I love my elective practice, and then I sprinkle in kind of the general surgery from, the acute care surgery stuff that I do.
Yeah, that's really great. Okay, one more question. Can you explain the concept of an interstitial hernia? It was tough for me to understand what you described. So yeah, interstitial means it doesn't go through all the layers and towards the testicle, for example. It kind of burrows its way through different layers. So before the last layer that it pierces, it actually like hits that fascia and then goes laterally. So it works instead of advancing as it grows anteriorly down the testicle in the groin, it goes through the abdominal wall layers. Actually, that's interstitial inguinal hernia. You can have any type of interstitial hernia. But the implication is that it pierces through different tissue layers, as opposed to going full thickness through all the layers. I don't know if that makes sense. Do you have a better way of explaining it?
Yeah, I sometimes call them intraparietal hernias too, so that I kind of explain they're not going through all the layers. So sometimes you don't see a bulge, or it's bulging in a place where you didn't expect because it's just taking a winding course through the abdominal wall. And sometimes it's not going through all layers of the abdominal wall.
Yeah, that's a better way of putting it.
No.
Okay, one final comment before we go, because I know your time is valuable. So thank you very much. Great thoughts from both of you. I'm not trying to suggest that I'm choosing the procedure, but I really feel like I'm getting a one size fits all or easiest response from my surgeon, and they're not considering my specific case, which is why I enjoy listening to Hernia Talk Live. For most all of your guests and me consider more things about an individual circumstance. So that's why I think they should see a specialist, because they can get that kind of feedback and consultation.
Yeah. And I would say, I know you do virtual consults if that's something she can do, or I don't think there's any harm in ever seeking a second opinion. I always want my patients to be comfortable with my plan for the operating room, because if they're not comfortable with the plan, it's not going to go well. So I'd say I don't think there's any harm in asking for a second opinion from another surgeon to see if they have a different approach for your individual case.
Exactly. And I love that you get that out of what we talk about, because I'm a big advocate of tailoring care. And I think that's how you can get the best results, which is not a one size fits all. But I do understand, especially if you go to a non-specialist, you may get one size fits all, because they know they know one really good way of doing things, and they apply that to everyone. And that may not be the best for you. And so do seek a consultation from a specialist. And if you have to travel. I just got a patient from Louisiana today, and they traveled, and it was great to meet them and give them the care that perhaps they couldn't have gotten locally.
Yeah.
Well, thank you so much. That was it. I appreciate it.
I can't believe it's already been an hour. So
right?
It was really fun. Yeah.
I know. I say that all the time. The time runs quickly. I have so much fun. I had a lot of great time with you. I will definitely share our video on social media. I think people will watch. It was 2019. So I was like 4 years younger, and you were still in residency.
And I'm embarrassed by the quality of my video. You said yours was bad at the dining room table. And I'm like, this is how my attending set it up for me to talk. And I'm like, now that I give talks internationally, it would have been done so differently. But I guess it's good to see how far I've come with my IT capabilities.
Exactly. We've all come. The pandemic has helped all of us. I love it. Well, thanks everyone for joining us. I appreciate all the comments and the questions and the interactions. If we didn't get to you, I apologize. Thanks to everyone who's on Facebook right now, live at Dr. Tofi, or those who found me on Twitter or Instagram at HerniaDoc. And don't forget, subscribe to my YouTube channel. This and all prior, I think we're up to like 100 and almost 140, 139 or something. episodes. They're all there. Watch them, learn from them, watch them again, subscribe on my YouTube channel at HerniaTalk, and I will see you again next week. Super excited because I've got tons of really great guests, just like Dr. Drexel. So thanks for your time, Sabrina. Appreciate it so much.
Pleasure. Thanks.
Thanks. Bye.
Bye.